This is a portable semi-sitting chest radiograph on a 76-year-old male patient who was admitted for pneumonia. The patient was admitted to ICU at the time. There is this ill-defined opacity which represented the known lower lobe pneumonia. This heterogeneous left lower lobe opacity obscures the left hemidiaphragm. There is a left pleural effusion as well. On a portable film, it would be difficult to accurately assess the cardiac size, but this is a known cardiac patient who had cardiac enlargement. There is a right PICC line standing for a peripherally inserted central catheter. This is another X-ray 2 days after. The PICC line has been removed. The pneumonia looks much better. The patient improved clinically and he was discharged from the hospital. This is a short-term chest X-ray follow-up after his discharge. The left lower lobe opacity has almost completely resolved. Notice how you could see the left hemidiaphragm in a better way here. The X-ray was taken with the ECG leads on. Now that's all good and fine, and that's not what I'm showing you the case for. Have you noticed something else? Now looking carefully, you'll see that there is this dense line here that we have to explain. The density of the line is very high, suggesting radiopaque material that could be metallic. And here's an illustration of the line in a better way. One of the things you could think about is a central line. However, a central line should descend from the internal jugular or subclavian. This is not the case here. This is not a PICC line. A PICC line should have a course that runs from the arm into the subclavian, then into the brachiocephalic, and finally into the SVC. For junior audience, this is not an endotracheal tube. An endotracheal tube should run within the trachea, and it looks totally different. It is not a pleural drainage tube. These are usually larger and look different and have a course that runs from lateral to central. This is not how surgical material should appear. The patient did not have surgeries anyways. And the question remains, what is this? Now, one of the important questions is this really in the chest or projecting from outside the chest? For example, this could be external from the patient's clothing, something related to his skin. Well, the fact that this was persistent on several X-rays as we saw makes it less likely, but the lateral would be very useful. This is the lateral chest radiograph here. And as you see, this confirms the presence of this linear dense structure. Now, remember, if you see a structure that appears to be inside the chest on frontal and on lateral projections, it is inside. Looking at both projections is an easy way to confirm the location of any abnormality that you see on a chest X-ray. Since this is now inside the chest, let's try to explain the course. We know the internal jugular vein joins the subclavian to form the brachiocephalic vein. On the left side, the same thing happens, and a brachiocephalic vein is formed to join the right brachiocephalic vein and form the SVC. The SVC then continues downwards to join the right atrium, which finally opens into the right ventricle. So looking at this structure that we're trying to figure out, you know that it's running in the SVC and terminating in the right atrium or the right ventricle. This is the CT scan that was performed shortly after, showing a right ventricle, left atrium, and right atrium. For juniors, you're looking at the patient from his feet, so this is anterior, this is posterior, this is right, and this is left. This is your left brachiocephalic vein joining the right brachiocephalic vein to form the SVC, and floating within the SVC we see our structure. The abnormality starts in the right brachiocephalic. It's a blinded abnormality, goes down to go into the SVC, goes all the way to enter the right atrium, which is dilated, and then it curls within the right atrium. This twinkling appearance is a streak artifact on CT, and it tells us that this is high density material, likely metallic. The reason this metallic linear thing is hanging there is probably because it's partially attached to the SVC here. Here's a coronal image, which gives us a better idea of what we were explaining on the chest radiograph. This is the left brachiocephalic vein meeting the right brachiocephalic vein to form the SVC. And you have the abnormality running in the SVC all the way down to the right atrium. And this is a sagittal CT showing what's equivalent to what we saw on the lateral chest radiograph. To really understand what's going on, let's go back to the patient's pre-admission chest radiograph before he had pneumonia. This is his chest x-ray before he was admitted to ICU, and there are no abnormal metallic densities. And this is his first x-ray after that, when the patient had a rocky course in the hospital. As you can easily appreciate now, there is the PICC line, and there is this abnormal density there. When any line is inserted, such as a PICC line, a guide wire that is metallic is used. So whoever is introducing the line goes through a small puncture into the vein and then uses a guide wire to help. Then he slides the catheter or the PICC line over the guide wire to reach the desired destination. Finally, the guide wire is removed and the PICC line is fixed in place. Unfortunately, in this patient's case, this is part of the guide wire that slipped into the vessel and went unnoticed. The guide wire was hanging there in the same way we explained at the beginning of the case, and the patient was discharged with this. This was picked up on the follow-up chest radiograph and then confirmed by the CT scan that I showed. The guide wire did not cause any symptoms, which is something that we commonly see with accidentally embolized material. However, the team elected to remove the guide wire, and this is a fluoroscopic image. This is the interventional cardiologist using his equipment to reach the IVC via a femoral venous axis and trying to retrieve this guide wire. And this is what's happening in front of you. Fortunately, the guide wire was not heavily stuck to the SVC to cause problems. Here's the same process on a lateral projection. See how they drag the guide wire? And the guide wire was removed through a transcutaneous vascular intervention without complication. This case is interesting, but the teaching points are very basic. First, a very important concept when reading chest radiographs is to start by tubes, lines, and equipments. Account for any support equipment, make sure the course and termination is right, and make sure you don't have extra material there. Second, know your anatomy and try to apply that on the chest x-ray, and this case exemplified the venous anatomy as we described. We know from prior teaching cases that lots of things could be extrinsic to the lungs, but look at two projections. If something appears in the heart or in the lung on two projections, it is indeed in. Fourth, when in doubt, performing a CT to confirm the location of the abnormality is not a bad idea. Fifth, an interventional radiologist or cardiologist could actually snare such an abnormality, hopefully with ease. Such a simple procedure would save the patient major surgery in case it was needed. And finally, if you're inserting a central line or a PICC line and you use the guide wire, please take it with you. If you're doing your first interventional procedure, the first thing that the staff would teach you is to be very careful with the guide wire. Thanks for watching. More cases later this week, and hopefully we're not going to see a case like this again. This is a sagittal T2 weighted MRI image of the thoracic spine in a 28-year-old female patient. This would be a very interesting case for radiology residents. It's also a good case to revise some simple anatomy of the spine. Now this is another normal case to show some anatomical landmarks for the juniors to understand what we're talking about. This is anterior where you have the heart. This is posterior where you have the back of the patient. This here is the vertebral body. This is another vertebral body separated by the intervertebral disc. Now from here to here, this is your spinal canal containing this dark spinal cord. As we agreed before, that water is white on T2 or fluid is bright on T2, this is CSF fluid. Remember that the CSF fluid surrounding the cord is a continuation of the subarachnoid CSF spaces above. Both the spinal cord and the CSF space are contained within the dura, so they're intradural structures. And this is the basis for classifying spinal abnormalities. Is it in the spine, which we call intramedullary, or is it outside the spinal cord but within the dura, the CSF space here, which is called extramedullary intradural? Finally, it could be something that is arising in the spinal canal but outside of the dura, outside of the CSF space, which we call extradural. Now to complete the picture of a normal case, this is a T1 MRI, also in sagittal plane. And as we know, fluid appears opposite to what we saw on a T2, so on T1 fluid is dark. Although there is a difference, it is difficult here to differentiate the spinal cord here from the CSF space surrounding it. However, since the cord and the CSF are dark on T1, on this acquisition it's easier to appreciate the bright fat adjacent to that. So this brightness here on T1 is corresponding to fat in the extradural space. Now, the bones that you see here posteriorly, these are continuous with the vertebral body and these are the posterior elements. That's it for anatomy. Let's go back to the abnormal case. Now you're an expert. This is a sagittal T2 weighted MRI. Anteriorly you have the heart. This is the patient's back. You know that this is the spinal cord that is dark. This is the CSF bright fluid surrounding it within the dural space. But this case looks different. The cord has an unusual appearance. Instead of having this normal course, it suddenly is displaced anteriorly. Because of this displacement, you don't have bright CSF fluid between the vertebral bodies and the cord, so the cord is attached to the bodies. You also have this CSF signal intensity expansion posterior to the cord. The cord then goes back to its normal course in a relatively abrupt fashion. Finally, the cord that should be dark as we agreed on the T2 image has this high signal intensity change here. You also see a similar appearance here, and such high signal intensity denotes myelopathy or edema within the spinal cord itself. Now, what are the possibilities here? The anterior displacement of the cord without CSF anteriorly with expansion of the CSF posterior is very classic. This is consistent with a rare condition that is known as ventral or anterior spinal cord herniation. The reason the spinal cord herniates anteriorly is because there is a defect in the dura. And the cord then herniates through this defect and is displaced forward. The defect in the dura that leads to this is typically idiopathic. There are many theories for the idiopathic reason for this, being adhesions or chronic disc disease. However, the exact mechanism for such an abnormality is not clear. Another cause for this would be a post-surgical defect in the dura. So in patients going for spinal surgery, there may be injury to the dura which leads to this. So in that case, it's not idiopathic. In this case, you have the hint to the diagnosis. Remember how we talked about these posterior elements here? Scrolling back and forth, you'll notice that the posterior elements are absent and you have some metallic artifacts, such as this here. So this is a patient who developed this anterior spinal cord herniation syndrome secondary to surgical intervention to the spine. In this case, it was not idiopathic, and the reason the patient underwent surgery is that she had a meningioma of the spine that was resected. The patient remained symptomatic, unfortunately, because of the anterior cord herniation and the associated myelopathy that we talked about. Now, another rare differential diagnosis that could simulate that would be a posteriorly located arachnoid cyst. An arachnoid cyst is a localized cyst that contains simple CSF fluid, so it would have the same signal intensity here. It would be somewhat difficult to differentiate an arachnoid cyst from an anterior cord herniation if you didn't have this history. However, the cord displacement by the posterior located arachnoid cyst wouldn't appear as abrupt. It would have a smooth displacement here and there. Another thing that you could try doing is to do a high-resolution, thin-cut, heavily weighted T2 MRI image to try to appreciate the wall of the cyst. Finally, a more invasive way is to inject contrast into the space here, a myelogram. With that, the myelographic material would fill the space easily if this is anterior cord herniation, versus delayed filling of the space if this were to be an arachnoid cyst. MRI or CT or fluoroscopic myelography could be used. Another difficult entity that could be entertained here is something related to adhesions within the CSF, something termed an arachnoid web. And in that case, the displacement would be very focal in the spinal cord. And you wouldn't have this long segment of involvement or the history of previous surgery. An arachnoid web is associated with a neat, recently described sign. So for seniors, what's the name of that sign? Feel free to answer that question here or on Twitter, YouTube, or other social media accounts that we use. One of the things that you should make sure of that this is not another entity that could displace the cord anteriorly, such as a hematoma, empyema, schwannoma, meningioma, or others. However, that could be easily assessed by looking at the other sequences, the T1, the FATSAT, and the post-contrast acquisitions. So let's summarize what we talked about. We started by simple anatomical facts, and we emphasized the location of the abnormality within the spine. Abnormalities within the spinal canal could be divided into intramedullary, extramedullary intradural, and extradural. We showed a classic entity of anterior cord herniation where the cord is displaced anteriorly without CSF space between it and the vertebral bodies. The anterior displacement is classically abrupt, and there is expansion of the CSF space posteriorly. Anterior cord herniation could be associated with changes in the cord and myelopathy, and may be idiopathic or a result of prior surgery. Really, the main differential diagnosis would be an arachnoid cyst or an arachnoid web. Although many times it is difficult, but we talked about a few ways where you could differentiate those entities from each other. Finally, by looking at all the sequences pre and post contrast, make sure that this is not something else such as hematoma, empyema, or a soft tissue lesion. Thank you for watching. See you with other cases this week.